Rhythm Interventions Online Control Centre in London. This is the RIO meeting, which is the first of its kind online interventional EP meeting. And good evening, good morning and midday to all of the delegates who have registered from countries around the globe. We have over 5,000 people registered in every continent apart from Antarctica. The aim of the day today and for the next 3 days is to give you 4 hours of interactive learning, focusing around live cases that are, we hope, of interest to you. It is very important that you engage with us because we are really interested to hear how you might manage atrial fibrillation in Fiji or how you might manage complex pacing in Myanmar. So please do send your questions and comments via the interactive system. Now, this is a purely and genuinely live course and all of the cases are live. So I want to assure you and the faculty that our role here is to educate, not to show off. So if things don't go right, as they may well not do, we will do everything that we would normally do with that patient, and our safety of our patients is going to be our #1 priority. We have CME accreditation, and so we hope that you will find this not only interesting, but also useful to your ongoing educational needs. We have some fantastic international centres from both sides of the Atlantic, and I'm very much looking forward to seeing how they approach these complex arrhythmia problems. Day 1, we're going to be focusing on making AF simple. Day 2, we're going to be focusing on making complex arrhythmia simple. And day 3, we're going to be looking at novel and newer technologies for pacing and resynchronization. I very much hope you enjoy the next 3 days. And my name is Richard Schilling. I'm the Professor of Cardiology at St. Barts Hospital, and I'm also one of the cardiologists at Barts Heart Health, where we are today. I'm going to go off and prepare for the first live case and pass you on to my fantastic co-course organisers. But first we're going to have a video showing us a taste of what we're expecting in day 1.
Welcome to the very first session of Rhythm Interventions Online. I'm Matthias Duitschaver from the Cardiology Department in Bruges, Belgium, and I'm delighted and honored to be joined today by 2 leading experts in their field. We have Dr. Jason Andrade, who is Director of the Electrophysiology Program and Head of the Atrial Fibrillation Clinic at Vancouver General Hospital in Canada. Welcome, Jason.
Welcome, thank you.
And one of the Rhythm Interventions Online co-course directors, Dr. Peter Spector. Peter is Professor of Medicine and Electrical and Biomedical Engineering at the University of Vermont, and also serves as Director of Cardiac Electrophysiology at the University of Vermont Medical Center, United States. Hello.
Hello, thank you very much. Pleasure to be here.
Jason and Peter, good to have both of you here. We've got a lot to get through, so I am going to hand you straight over to Jason, who is going to talk us through day case AF ablation. Is this a priority? Please, Jason.
Thank you very much. It's my pleasure to speak to you about day case ablation or same-day discharge after atrial fibrillation ablation. So here are my disclosures. As a matter of background, I looked into some of the costs associated with atrial fibrillation ablation, and it was interesting to see how varied this is across the world. So I'm highlighting in this box, this is an American gentleman from Washington who went off to Bordeaux and had an ablation in about 2016 or so. And so his ablation was associated with a 5-day stay and a cost of about 16,000 euros. But if you look just below, he reports the cost that he paid within the American healthcare system. So at the University of Washington Hospital, his ablation cost $75,000, which was negotiated down by his healthcare insurance to $48,000, of which he paid $3,500 out of pocket. And so in preparation for exploring this topic, I had put out a poll on Twitter to the electrophysiology community and basically trying to see what people's default was in terms of their ablation procedures. And you can see that 68% had a default of keeping their patients overnight. Some were kept 2 nights or 3 nights. There was a minority who were practicing routine same-day discharge. Obviously, we all know as electrophysiologists that atrial fibrillation is a very common disorder. It's a very prevalent disorder and something that we're going to encounter more and more. Because it's so common, it ends up being a very costly disorder to the healthcare system. So if we look at some jurisdictions within Europe, the UK spends about 2.4% of its annual healthcare budget on the care of atrial fibrillation, with similar numbers in France and Italy. So because it's so prevalent and because it's so costly, there's obviously an implication to national health services. When we break down those costs by the components, most of the spending in direct care costs comes back down to acute care. So emergency room visits, hospitalizations, and procedures. And so that's obviously an area where there could be potential cost savings. We look at the rise in atrial fibrillation ablations, you can see that it's becoming more and more common. And so therefore, ablation on the whole is occupying a larger proportion of that acute care cost, which is the majority of the healthcare spending. Now, this data is a little bit harder to tease out in terms of finding out how much the hospitalization costs relative to the fees paid to the staff versus the disposable costs. But looking across a couple of publications, you can tease out that it seems to be pretty consistently around 15% within North America and Europe. There was a publication in Australia where it was as high as 30%. So just conceptually, if we think about this from a healthcare system standpoint, if we can eliminate the costs associated with the hospitalization, there could be significant savings, and it may allow us to then consider doing more procedures within the same stretched healthcare budget. So the big question that then comes back is, can we safely discharge patients the same day after a procedure without compromising any of these clinical outcomes? In this regard, the evidence is relatively new. There's a few publications in this domain. Essentially, there's 7 cohort studies that have been published to date. The first was from Lucas Hagley when he was a fellow at Royal Jubilee Hospital in Victoria, British Columbia. Effectively, this is just a feasibility report. So it reported the outcomes on 230 patients, of which 205 were able to be discharged on the same day, but didn't really take it further. So didn't look at anything to do with the consequences of discharging people earlier. More recently, there's been 5 series. These series, I've grouped them together because conceptually they view the concept of same-day discharge through the same lens. So essentially what they are looking at is a default of overnight observation, but then examining their population of patients to see who's low enough risk where it may be feasible to discharge patients the same day. And so there's a common thread running through these 5 studies. Opal used a matched analysis between day case versus patients undergoing ablation at the main university center. The other cohorts, you can see it was about a third of patients who were able to be discharged same day, when 2/3 ended up having to stay overnight. When you look across the criteria, the common thread emerges. So typically, if you're trying to pre-specify who could go home on the same day, essentially what you're looking at are patients who live local, patients who have caregivers or supports at home. Most often, it was the morning cases, so earlier finish times allowed for longer observation in hospital and therefore same discharge. You were less likely to have gone home if you had a late finish. In terms of the procedure itself, it tended to be conscious sedation. Patients who received a general anesthetic were less likely to go home same day. So what I'm showing you on the left side is general anesthetic use in the population of same day versus the population that's admitted. So for example, in Reddy et al., 29% of the same day discharge had a general anesthetic, whereas 60% of the overnight stay did. Beyond that, because there's no general anesthetic, then typically these are patients who did not receive a transesophageal echocardiogram and did not need a cardioversion during the case. These are contemporary series published within the last 2 years, so most of the patients received a femoral closure device to minimize the risk of groin complication. And in general, the patients were picked out if they were undergoing less complex atrial fibrillation ablation or cryoballoon ablation. And you can see that about 80% of patients in the same day discharge group had a cryoballoon, with only about 20% in the more later series, versus RF, which was the predominant modality used for those that were kept for observation overnight. This translates out into same day discharges typically having a shorter procedure duration, but I think that's more of a function of cryo rather than the complexity of the case necessarily. If you look at the acute complications, there does not seem to be a difference in these series between the same day discharge patients and those kept overnight for observation. But again, recall these are patients who are selected because they're low risk. And so you shouldn't expect that they're going to have a higher rate of complication, otherwise you wouldn't have picked them to go home the same day. The biggest deficit of this evidence base, though, is there does not appear to be much outcomes beyond the hospitalization. So what they're telling us, at least in these series, is that it's feasible from an acute perspective, but we don't know what happens to those patients after they leave hospital. So our series took a slightly different approach. So if the current evidence is saying, well, let's pick out the lowest risk patients so that there's a safe discharge, and we'll keep everyone else who's intermediate or high risk, our approach in British Columbia has been the opposite. So essentially, we view every case as a same-day discharge, and we're only planning for overnight stay in the higher risk cases, so those that we're more worried about. But everyone else, on default, is going home. Our protocol for our series, so we had 3,000 patients in our series from 2010 to 2014. Patients were admitted 3 to 4 hours prior to the procedure. Interruption of anticoagulation was at the discretion of the operator. Again, the era of our case was there was no routine ultrasound-guided access and no femoral closure devices. Following the ablation, patients were kept on bed rest for 3 hours and then discharged home if ambulation was tolerated, and they resumed their anticoagulation that night. So of our 3,000 patients, most of our patients were general anesthetic. So almost 99% of our AF ablations occurred under a general anesthetic. Because of the era of our cohort, most were radiofrequency, so about 96%. Our updated analysis will include cryo, and we'll report that shortly. But for this series that was published last year, it's mainly general anesthetic, mainly radiofrequency, 40% persistent AF, and this is in the pre-STAR AF era, so with lines and cafe. And about half the patients had uninterrupted anticoagulation. About half of the remaining were interrupted NOACs, and then a minority were interrupted warfarin. When we look at the outcomes, about 80% of the 3,000 patients achieved same-day discharge. So again, the default is to send people home, and we're only holding back those that are higher risk. And so what that did is it allowed us to look across 3 groups. So on this slide in blue, you have same-day discharge. In red, you have patients with a planned admission, so those who are identified at high risk, who are going to keep overnight. And then you have the gold, who are those that were admitted because they had a complication. And so if you look at now the outcomes after hospitalization, so 48-hour readmission. So the idea that if we are discharging patients the same day, are they going to then immediately come back to the emergency room? And so in the 48 hours following the procedure, there was a numerically lower rate of readmission for those who went under same day, although it was not significant. Both groups had less readmission relative to the group who were admitted with complication. But then we also looked beyond that. So now we looked at 30-day readmissions and 30-day complications. And so this is splitting it up slightly. So in red is the complication rate. In blue is the readmission at 30 days. And so the complication rates, if you can see on the slide, are small. So the 30-day complication rate in the same-day discharge is 0.37%. In the group that was held overnight, the 30-day complication rate was 0.36%, so no different. So the default plan of discharging patients home did not result in immediate readmissions in 48 hours, did not result in late complications, so something like tamponade or stroke that you may have missed by discharging them immediately, and it did not result in an increased rate of readmission. So on the whole, sorry, I'll just step back here. When we look at all of the evidence regarding same-day discharge, I think we can take the view that same-day discharge can be achieved in the majority of our patients safely with minimal risk in terms of readmission, in terms of complications, or in terms of late complications. I think that there's value in the approach that was taken for the 5 series of identifying the low-risk patients and focusing on the lower-risk procedures. But I would argue that our evidence provides a broader perspective to say that this is something that can be achieved for the majority of atrial fibrillation patients. If we think back to that early slide I showed you, if 15% of our procedure cost is tied to that admission, then by achieving same-day discharge, we can result in incredible savings to the healthcare system, which would allow us to do more of these procedures under the same healthcare budget and ensure that we're able to treat patients adequately and quickly for their rhythm disturbances. So thank you very much.
Thank you, Jason. Clear presentation and very clinically relevant data. One question. I think many operators still feel that the decision to discharge should be adjudicated on a case-by-case basis. But what do you think regarding the operator experience? Because data are coming from highly experienced operators. What is your comment?
So I think that there's probably 3 elements to it. So the first is, of course, it's going to come down to a case-by-case assessment, right? I think the perspective I'm trying to show is patients who are adequately prepared at the time they make the decision to have their ablation, that they realize that this is going to be a day case procedure, and they make preparations to have support at home, people who will look after them. Then when they go into the procedure, recognizing that this is a day procedure and I'll be home later in the day, they can be prepared to deal with any consequences that come. As a clinician, I can then identify patients who are at higher risk, who I'm worried about, who may need to stay overnight, and then I can make those preparations ahead of time. I think the problem is the opposite. So if your default is that you're keeping everyone overnight, it's hard to convince a patient that, no, I know we said we were going to keep you in hospital overnight, but really we don't have to. You can go home. I think that that's a bit of a different perspective for the patient's preparatory piece. The other side is that you have to have something to help the patients once they go home. So, our atrial fibrillation patients are called within a week by the atrial fibrillation clinic to check in to make sure that everything went well, that there were no problems or no issues, but they're also given that resource number. So I don't think you can discharge people without support from the healthcare team or without support from the carers. Now, the last piece has to do with, operator experience. Definitely, this is an experience issue, not just for the operators, but also for the hospital, right? So if the hospital has been doing this for 10 years, and this has always been how we've done, we clearly have created a support infrastructure that's there to make sure that a patient doesn't fall through the cracks. If we have, inexperienced operators where there's potentially a risk of complication or a different outcome, then you may want to hold those people longer, because therefore you're not going to get into trouble with people leaving and then immediately coming back in with a groin complication or something else. So I think it is a site-by-site decision whether this type of practice is right for your site or your operators, as well as there's a work that goes into ensuring patients are comfortable with this type of approach and that they're not going to have anything missed in the process.
Okay, thank you very much, Jason. I'd now like to pass over to Peter, who is going to talk about what to do when pulmonary vein isolation fails. Please, Peter, go ahead.
Hello, first of all, let me thank Rio for inviting me to participate in this conference. Dr. Schilling said at the outset that we wanted to talk about making AF simple today. And I think, unfortunately, he then assigned me a topic about which one really can't simplify atrial fibrillation. So the title of the talk is What to Do About Atrial Fibrillation When Pulmonary Vein Isolation Alone is Not Sufficient to Cure the Fib. I think another way to state that question is to say, if isolating the pulmonary veins is not enough to prevent fibrillation, what can we do that will allow us to modify the atria's capacity to support fibrillation? That's not a question that I'm going to be able to answer in 10 minutes, so just give you fair warning. But I'd like to frame the question a little bit for purposes of discussion. So for starters, let's talk about the areas of agreement and areas of disagreement within the field of EP. I think there's a fair amount of consensus out there that while pulmonary vein isolation is effective in treating patients with paroxysmal atrial fibrillation, it's not always sufficient for all patients with atrial fibrillation, even though it's probably required in all patients. I think that while there's agreement about the fact that often PVI is inadequate, there's really not a lot of agreement about what the additional ablation that's required should be. Over the years, we've seen all sorts of answers to the question, from cafe ablation, GP ablation, linear ablation, firm ablation, etc. But at no time did I think that we saw consensus across the field on what was appropriate. And I also think that there hasn't been any consensus to this day about how you answer that question, which is probably related to the fact that there is no consensus. So one reasonable question to ask is, why is it that there's still disagreement at the end of 2020? And I'd say that the answer is that no one's ever actually seen human atrial fibrillation in the way that we have seen animal atrial fibrillation, for example, with optical mapping techniques and so forth. So I think that it is due to the inadequacy of our current mapping technology that has introduced this vacuum of information that's been filled with debate across the field. So here's a video of my opinion of what fib might look like if we could really see it, but we only get to see it through our electrodes, which gives us a very limited sample, and those electrograms are blurry, as I'll extrapolate in a moment. So we're using very sparse and inadequate data to try and identify a very complex rhythm, and then thereby be able to look at and decide what's driving atrial fibrillation in this patient, where is that atrial fibrillation being driven, and therefore what's a rational, patient-specific, and mechanistically guided ablation strategy. So I think one of the big challenges that we face is that atrial fibrillation was first defined, 150 years ago in the best way possible at the time, but in a way that is no longer adequate. AF is defined observationally. It's just a rhythm with changing activation. And the reason that it matters that we have an observational rather than a mechanistic definition is that it's become very clear from data over the last 150 years that there are multiple different mechanisms that can result in that phenotype, changing activation. We've seen data that supports focal drivers with fibrillatory conduction. We've seen compelling data and, for example, the response to the surgical maze procedure that support the notion that atrial fibrillation can also be driven by multi-wavelet reentry, by dynamic, spatially changing drivers of fibrillation. We've seen very compelling data out of Dr. Fedorov's lab, human optical mapping ex vivo hearts, that structural microreentry can drive fibrillation. And finally, out of Alessi's group and others now, we've seen data that suggests that particularly in chronic atrial fibrillation, you can have diffuse shifting structural reentry from endocardial-epicardial dissociation and waves crossing from one plane to the other, maintaining fibrillation. And the key point about all of that is that the appropriate and rational ablation strategy for modifying those rhythms entirely depends upon which one of those mechanisms is active, and if more than one mechanism is active, which mechanisms are active in an individual patient. So I think that there's debate today because we aren't adequately defining the rhythm pathophysiology in individual patients. And I'd just like to say parenthetically that if you look at the literature for the last 20 years, it's somewhat troublesome. It appears that patients that are doing ablation studies on the exact same type of AF patient are getting wildly different results. So one study will say that treatment X has a 90% success rate. The next study looks at the same patient population, the same treatment, and they get a 25% success rate. And this has happened over and over again for the last couple of decades. And I think the reason is that we're not looking in a fine enough way at the patients. And so what we are calling the same patient population is not the same patient population, and that's why they don't respond the same way. So let's move on to how one might answer the question, what is it exactly that's driving atrial fibrillation in an individual patient? And to do that, let's talk about what's inadequate about our currently available tools. So here's a video that shows in a model this zigzag activation pattern. And in this, if we're looking at electrical activity with an electrode that has very poor spatial resolution, meaning it looks at a large area, we get a fractionated signal because we see a deflection for every one of these independent pathways of electrical activation. As we improve our spatial resolution and look at an area small enough that there's organized activity, we see an organized electrogram. So one of our problems with mapping with current technology is that we have an ambiguous local activation time because we often have fractionated signals, and that we have that because of inadequate spatial resolution of our electrodes. So this is from some work from Alessi's group where they've shown with epicardial mapping in the operating room in humans with persistent or long-standing persistent AF that you get very complex activation. Here we're seeing 1, 2, 3, 4, 5, 6, 7, 8, 9 different waves in an area that's a few centimeters squared. And this gives rise to these complex activation patterns and makes it very difficult to discern what's going on. There are those that have used fractionation itself, cafes, as a metric for identifying the driver sites and targeting those sites for ablation. And I think that that's inadequate because fractionation isn't a meaningless thing, but it's a non-specific thing. You know, we were all introduced to fractionation in the scars of ventricular tachycardia 30 years ago, where the zigzagging activation gives you a very fractionated signal. There's been many computational studies that show that the greater the degree of fibrosis and fraction and disruption to propagation, the greater the amount of fractionation you get in the tissue. It's important to notice that while those prior two examples don't necessarily identify a driver region and a real target for ablation in atrial fibrillation, here's a study that indicated that you can have a shifting rotor that causes fractionated signal, and that this may very well be a driver of fib. But there are other studies that show that if you have a rotor that's driving fibrillation but is stationary, you get a completely organized signal. So fractionation is not sufficient to guide ablation. The next issue that plagues us is an inadequate sample density. So here's a map that looks like we have focal activation traveling in this direction, maybe a focus in the right atrium. But if you look at this, it's the map is based upon a small number of points highlighted with these circles. When we get more data, you can see that this is the map of the exact same rhythm, that in fact we have reentry on the free wall. And had we had a higher sample density, rather than ablating at these foci, which would have done nothing, we discovered that we need to do a linear ablation to transect the circuit. So what do we do when pulmonary vein isolation isn't sufficient to cure atrial fibrillation? I think the answer to that question is going to require patient-specific, mechanistically guided ablation. And in order to do that, we're going to require high-resolution electrodes, and we're going to have to achieve adequate sample density despite changing activation. And I think I've been true to what I said at the beginning, which is I'm not going to answer this question for us today. But there is one important thing that I'd like to point out, and that is in the absence of a clear guide to what we should be doing in ablation, we shouldn't do things that don't make a lot of sense. I think that you can do a lot of additional ablation because you feel like you have to do something, and we often set up the substrate for atrial tachycardia when we do that without fixing the atrial fibrillation. So I would recommend caution when pushing forward with ablations that are of unclear effect.
Okay, thank you, Peter. We have 2 minutes before we go to the live event, so we will respect this. I've started mapping 20 years ago with Maurits Alessi, and at that point I realized that it will be so challenging to map direct activation. Yet you are still making the background for high-resolution mapping and high-density mapping. How should it look like? Is it multiple catheters, software that can annotate activation times? Just give us a guess how it will look like.
Yeah, so that's an excellent question. Obviously, it's a difficult problem to solve, or we'd have solved it already. My opinion is that we can overcome the spatial resolution problem with better designed electrodes, and we've done that in our lab here. That allows you to get very organized signals even during atrial fibrillation. The real challenge, though, is what do you do to achieve adequate sample density? And I think that you're correct. There's just no way to deliver enough electrodes to the heart in order to get adequate sample density. Would require 1,000 or more electrodes, for example. What we need to do, just to give you sort of a teaser, not really answer your question, is find something that spatially correlates with the drivers of fib, but that isn't changing with time. And if we can do that, then we can map sequentially, which is what we do in all other organized rhythms, to solve our sample density problem. So if we can use high resolution electrodes to identify something that doesn't change with time, that does identify drivers, we can make an arbitrarily high sample density map, and I think that's going to be the solution to the problem.
Okay, good comment. Thank you for this. That brings us to the close of this brief session. I would like to thank both of you for your fantastic presentations, both Jason and Peter. I would like to invite you to join us for session 2, which is a live case from the course director, from Richard Schilling. And the topic is minimizing X-rays during atrial fibrillation ablation.